Hi, good evening, and welcome to the final event in this series of everything you've always wanted to ask about diabetes care in people of African and Caribbean origin. My name is Bernadette Adela Catrax, and I'm the founder and COO of Diabetes Africa. Diabetes Africa is a nonprofit organization. We were established in 2019, and our goal is to improve diabetes care for people based in Africa, but also people of African origin globally. And we do this by communicating, connecting people. And part of what we do like this is to raise topics and increase awareness about things that are very important to diabetes care. Today, we're going to be talking about adapting to the pandemic. And we've got two experienced speakers from our UK expert network who are going to go across some interesting topics this evening. As always, this is an interactive event. The speakers will be available in the chat. Please feel free to put your comments and questions and feedback in there. We want a lively discussion. This series would not have materialized without the support of our partner, Novo Nordisk, who have not been involved in creating the agenda, selecting the speakers, or curating the content, but have enabled this series to go ahead. So thank you very much for your support. We are joined by Dr. Joan St. John and Dr. Glenys Williams, who are going to walk us through some of the insights in adapting to the pandemic. So we're moving on to the first presentation. Joan, could you introduce yourself, please?
Thank you very much, Bernadette. My name is Dr. Joan St. John. I'm a GP with special interest in diabetes, working in Northwest London, and I'm also a Diabetes UK clinical champion. So thank you very much for inviting me to speak about adapting to the pandemic, how that's affected African and African Caribbean populations with diabetes. I'm going to be talking about various aspects of this really important topic, about how African and African Caribbean people have been disproportionately affected by COVID-19. And I'm going to highlight that particularly with evidence from the early stages of the pandemic. How people living with diabetes have been disproportionately affected by COVID-19. And again, a lot of the evidence has come from the early stages of the pandemic. About the vaccine and how that has affected African and African Caribbean people, and also how the pandemic has highlighted health inequities, and then the emergence of trusted messages and the messengers as well. So the first thing to point out when we try and look for evidence and information about how African and African Caribbean people living with diabetes or cardiovascular disease may have been affected by COVID-19 infection or the vaccination, it's difficult to find that information. You can find information about African and African Caribbean people and the COVID-19 infection or vaccination. You can separately find information about people living with diabetes or cardiovascular disease and COVID-19 infection or the vaccination, but trying to find information about African and African Caribbean people living with diabetes or cardiovascular disease and the infection or vaccination is very difficult to find that evidence or information. But let's have a look at the information we've got. So a lot of the information that informed our understanding of the impact of COVID-19 infection came from the Open Safely study, which was a cohort study done at the beginning of the pandemic, the beginning of when the pandemic affected places like the UK. So it was done between February and March 2020. And that gave us a lot of information. It's a cohort study, so it's not talking about causation, it's talking about association. But what were the factors that we found that were associated with, unfortunately, mortality with this infection? So the most common association was with age. Undoubtedly, it was with age. But it also highlighted certain things to us. So ethnicity seemed to be associated with an increased risk of mortality, as did deprivation, but I'd also like to point out, as did diabetes. And diabetes of itself was associated with an increased mortality rate, but so-called uncontrolled diabetes, and that's only with an HbA1c above 58 millimoles per mole, was greatly increased mortality rate compared to people who had an HbA1c of around 58 millimoles per mole. Now, there were other associations that became apparent from this open safety study. Things like chronic kidney disease, things like heart disease, things like malignancy, neurological disease, dementia. But as I say, at the beginning, it was age that was the most associated with an increased mortality risk. So, Public Health England had to do a narrative review following on from this information highlighted by the Open Safely study. And they found in the first wave of the pandemic that there was this increased mortality rate in certain groups. You can see on the left-hand side here, in terms of what is called Black and Black British ethnic minority populations, there was an increased risk of diagnosis, but also if you look at the graph on the right-hand side, an increased risk proportionally of being admitted to hospital. Not only that, but the level of care required when you're admitted to hospital was also disproportionately increased. And sadly, when we looked at the age standardized mortality rates by ethnicity, it became apparent that people of the Black and Black British communities, ethnic groups, were at increased risk of mortality from COVID-19 infection. Remember, this is from the first wave, from early on in the pandemic. And that was the headlines that caught everybody's attention when it was said that Black men were 3 times at increased risk of dying from COVID-19 infection compared to the white population, which was the reference population. So when we try to find information about comorbidities, and when we say comorbidities, we mean other conditions, other medical conditions. There's some information here showing that there was an increased proportion of people with hypertension on that death certificate if they died from COVID-19. An increased proportion in the Black community, the Black ethnic group, compared to the white ethnic group. So 17% in the white ethnic group, 40% in the Black group, but it was also high in the Asian population as well. And we would expect that people from the Black community would have a higher prevalence of hypertension because we know that there is an increased risk of hypertension in the Black community. But when we try and look for diabetes information related to ethnicity and the COVID-19 infection, it was a bit more difficult to find it, but I was able to find it in this narrative review. So let's look at the information about diabetes, COVID-19 infection, and ethnicity. So in death certificates, the proportion of COVID-19 deaths where diabetes was mentioned was higher amongst males than it was amongst females. And unfortunately, with the COVID-19 infection, we found that the mortality rate in men was greater than in women. So that's in line with what we found with the infection. And as I said previously, age was also a risk factor for death. But diabetes was also more likely to be mentioned on the death certificate, and more so in deprived areas. So social deprivation also increased the mortality rate alongside that additional factor of diabetes. So let's look at ethnicity. So if we look at the death certificates where diabetes was mentioned, it was 18% in the white ethnic group, 43% in the Asian group, but 45% in the Black ethnic group. So we can see this disproportionate effect on the Black community, African and African Caribbean peoples living with diabetes who unfortunately had the infection and unfortunately succumbed to that infection of COVID-19. Let's now look separately at the situation for diabetes. So, this systematic review, conducted again in the early stages of the pandemic, showed that in type 1 diabetes, COVID-19 related mortality was significantly higher in people of Black and Asian ethnicities. So, Black and Asian ethnicities were put together in this systematic review. So, if you look at a population size of 3.5%, the mortality was 10.1%, with a hazard ratio of 1.77%. Looking at type 2 diabetes and the COVID-19 related mortality, it was again significantly higher in people of Black, Asian, and mixed ethnicities. A population of 4.8%, but a great mortality rate, greatly increased mortality rate, of 8.4%. Hazard ratio is 1.63. So this information is telling us that diabetes of itself increased the mortality rate if you were unfortunate enough to catch COVID-19. Being of a Black ethnic group increased the mortality rate if you were unfortunate enough to catch COVID-19 infection. And if you had both things, that also increased your mortality rate. Currently, and this changes by the day, in the UK, were over 128,000 people who lost their lives to COVID-19 infection, but we have to look globally. And globally, nearly 4 million people have lost their lives to this COVID-19 infection. It is a global pandemic, and it is absolutely the case that none of us are safe until all of us are safe. It was a devastating effect on the Black community, the COVID-19 infection. And so when the vaccine came along, I think it was expected that the uptake for the vaccine would not be any different in the Black community compared to other communities. However, the headlines started appearing that about 30% of Black or Black British adults reported some vaccine, I'm going to call it lack of confidence. And this was the highest in all ethnic groups. So 30% of people had a lack of confidence in the vaccine. And you'll see on the right here, when you look at people who are over the age of 70, and remember, I said that age was one of the biggest risk factors for mortality with COVID-19 infection. So people over the age of 70, still the lowest groups to take up the vaccine were the Black African and Black Caribbean ethnic groups. It's so important to understand and acknowledge some of the concerns that the Black community would have with regards to the vaccine and where these concerns arose from. If we look at things like the historical and unethical trials on people of color, for example, the Tuskegee trial, which was conducted in the United States of America between 1932 and 1972. It was a trial looking at untreated syphilis in African American men. Now, it was unethical because even when treatment became available for syphilis, the Black men in this trial were denied treatment. Also, they weren't given full information in order to give their consent. And this led to the men dying, their spouses becoming infected, their children having syphilis, and it resulted finally, when the trial was stopped, with the American government and the American president at the time having to apologize to that community for the totally unethical trial that was conducted in that community. There's a lack of trust in authority, and where does that come from? Well, in the UK, very recently, the so-called Windrush scandal has caused people to have some lack of trust in authority. So families were invited to help restore the UK following the war. People who were here legally and legitimately were suddenly asked to provide evidence that they were here legally and were treated as though they were illegal immigrants and were denied access to things like medical care, lost their jobs and livelihoods whilst they were asked to provide this evidence, and were threatened, and some were actually deported. And again, there has been an apology to people from the Windrush scandal who were affected by this by the UK government, and compensation is being given slowly to them. Some people have concerns about vaccine safety, and we'll say a bit more about that. And there's also some disinformation which is spread through social media, as well as cultural beliefs and concerns about religious compatibility. So people were concerned about whether or not there was alcohol or things like that in the vaccines. And there is some systemic racism in medicine. We have to accept that. And all of these things cause the Black community, African and African Caribbean peoples, to have some concerns about the vaccine, despite the disproportionate effect of the infection on these communities. With regards to individuals had sort of three main concerns. Is it safe? If I have a medical condition, will it make it worse? And some people felt that they just weren't ready yet. So when people were saying, is it safe? They were concerned about the side effects and what might happen to them, both now and also in the future. So things like fertility, breastfeeding, and pregnancy were very much a concern for people from many different communities. But also people felt that if they had a medical condition, perhaps taking the vaccine might make it worse, because some people thought that there was some virus in the vaccine. And so therefore, if they had a medical condition, would taking the vaccine make it worse? But actually, there is no virus as such. There's no live virus in the vaccine. It is the covering of the virus, which is used to promote and precipitate an immune response. So it's absolutely safe for people who have a medical condition to take the vaccine. In fact, as you can see from the previous slides, with the increased mortality rate in people who are living with these conditions, is actually of benefit to take the vaccine to protect yourself rather than not take the vaccine. So people's concerns about medical conditions needed to be answered and informed so that they could make an informed decision. And then others felt that it was a new thing. The infection itself is a new thing. So the vaccine was a new thing, and they wanted to wait and see how others are, or they were only going to take it if they needed to for work or to perhaps travel to the Caribbean, to Africa, to anywhere in the world. So there was an emergence then, and a need, a request for what we call trusted messengers and messages. So on the left, you will see various healthcare professionals who work in an NHS trust who were reaching out to colleagues within that NHS trust who had those same concerns as the rest of the community and wanted those answers to those specific concerns. So there are what were called truth boards. So the COVID vaccine won't change your DNA, or it's safe to take the COVID vaccine if you have a medical condition. And there were various truths that were put up on the boards and small snippet videos to help answer some of the concerns, as well as drop-in sessions to answer the concerns of the community. Professor Kevin Fenton did a wonderful review to understand the impact of COVID-19 on Black, Asian, and minority ethnic groups. And there are some fantastic recommendations about the way to take things forward in the future. So in summary, it is difficult to find information about African Caribbean people living with diabetes or cardiovascular disease and the COVID-19 vaccination and infection. But it is possible, if you dig deeply, to find that there was a disproportionate effect on African and African Caribbean people living with diabetes or cardiovascular disease from the COVID-19 infection. With the vaccination, we're going to hear some more information about a fantastic report that Dr. Glenys Williams and Dr. Natalie Darko have done to inform us and give us some more information about what people from African and African Caribbean people felt and think about the virus and the vaccine. And what I'll leave you with at this stage is what we need to do now is see the way forward on the basis of the information we had from the first wave in terms of the evidence that's been presented, but also from the information that Dr. Williams is now going to present. How do we make sure that the future is going to be better for African and African Caribbean people living with diabetes if there is another crisis that occurs? Thank you.
Thank you very much, Joan, for that great presentation. It was lovely to have an overview of the history behind why people might not have confidence in the healthcare system or might be cautious about vaccines, and then some other things that are going on in the environmental space which might have an impact, and showing some of the results for people who have COVID-19, who are of Black ethnicity, and also have diabetes or cardiovascular disease. And I would like to welcome Dr. Glenys Williams, who's going to be talking about the results from a recent survey relating to COVID-19 vaccines in the UK. Glenys, I was wondering if you could introduce yourself, please.
Thank you, Bernadette, and the team at Diabetes Africa for giving me the opportunity and this platform to deliver our survey report. And thanks again, Joan, for your excellent presentation, which has set the scene of the background for our report. My name is Dr. Glenys Williams. I'm a general practitioner working in Chiswick, West London for over 25 years, but I also have specialist interests in medical education, inclusive of postgraduate and undergraduate teaching in medicine, as well as working in diabetes care, in secondary care, primary care and community care for the last 25 years. I also carry a portfolio working with the National Institute of Health Research, looking at primary care-based research. So my talk really I need to orientate you into the environmental context that this report and survey has been generated. And it's a survey amongst the Black, Asian, minority ethnic groups, for which I will use the term BAME or BAME from now on as an abbreviation. And I'm going to give you a timeline in terms of the time and place and the communities that spearheaded us to conduct this survey. I will start by giving you the conclusions of our survey report, and then I will go into the experiences that led us into why we designed this report, the methods that we used, and end with the recommendations that we've come up with. So our conclusions were that the terminology vaccine hesitancy really relates to informed consent. Informed consent is part of medical ethics, which is part of good medical practice as recognized by the General Medical Council. And this allows individuals to make their decisions or their choice to take treatment by considering the risk-benefit ratio of that treatment. So the risk could be the safety concerns of short and long-term effects of the treatment, or maybe relating to underlying previous medical conditions that they already have that could be a contraindication to them taking that treatment. And of course, the benefit would be the protection, in this case, from the virus, protection from severe illness or death. So I think that it's really important, as Joe mentioned, that there was a lack of confidence in the vaccine. but really our survey has shown that people wanted more information to make sure that their health was protected in taking this vaccine. We also have demonstrated, as Joan has also mentioned from previous smaller studies, that there is a lack of trust that needs to be addressed. And this lack of trust is both historical and also current, as people have experienced racism in the past or within whilst they're using the healthcare system. And this needs to be addressed because it ties into informed consent, because you need to trust the delivery of the service, you need to trust the treatment, that it is safe for you to take it. People have also given us information about their preferred channels of communication in delivering the information. And this also links into lack of trust. They need to trust the providers of the healthcare system. They need to trust the healthcare professionals, and they need to have their questions answered so that they can give consent to treatment. We also identified diabetes-specific results, which were concerning because, as Joan mentioned, people living with diabetes had a higher risk of poorer outcomes following the COVID infection. So it's important that they are protected. And at the same time, the Black, African, and Caribbean population are more at risk of developing type 2 diabetes. We realize the importance of research, such as what we've done, but probably deeper research to understand the information required by different communities for informed consent and to improve trust. We need these bilateral conversations so that we can enable vaccine uptake in this particular case. So I'm now going to just go into the timeline that I was experiencing, which made me think about conducting the survey. As Joan mentioned in her talk, in 2018, there was the Windrush scandal, which was an abuse of immigration rights to a group of people from the Caribbean who had worked here for over 40 years in health and social care. And at one point, their information was destroyed or deleted in the Home Office, and they lost their right to remain in the UK. This was addressed with a bill in Parliament, and people up till today, I believe, have not been fully compensated for this gross mistreatment. And in 2019, the COVID-19 epidemic was declared in China, and by February 2020, the WHO had declared this a public health emergency of international concern, which meant that state governments could now make decisions about protecting their borders from the risk of this infection. So in the UK, on the 23rd of March 2020, we started with non-pharmaceutical interventions called COVID restrictions, as well as our government invested into research for vaccine development. By 2020, the other significant event in our timeline was that there was the murder of George Floyd by a police officer in Minneapolis, and it started and triggered a civil rights movement, which cascaded via the engines of globalization with the use of information technology and social media networks into a global human rights activism movement. By December 2020, we had started vaccinating in the UK, and this was a novel, amazing, exciting time for healthcare professionals, because despite the restrictions reducing the rate of infection and therefore improving morbidity and mortality in the UK, we knew that COVID restrictions would cause fatigue, they were affecting our mental health, and they had a significant effect on GDP. And in the past, it has always been vaccinations that have resolved pandemics. And for the first time, we had an innovative, fast-track, effective process in creating a vaccine. This vaccine was effective between 92 to 96% after 2 doses. So for a healthcare professional as myself, this was really exciting. And I felt that it was going to have an impact, and I was expecting all communities to be involved in taking the vaccine. But yet, by February 2020, the information from the ONS, the Office of National Statistics, was saying that 44% of Black British adults were reporting vaccine hesitancy. The term vaccine hesitancy had evolved, and this was the highest of all the ethnic groups that showed a delay in uptake of the vaccine. And I began to think about public consciousness for Black people, that we could see the George Floyd movement in parallel, and were Black people thinking they were not experiencing individual human rights within the justice institutions that were protecting the community human rights. So therefore, would they experience and believe that their individual right to health was going to be protected during this vaccination program, whilst the state institutions were trying to protect the community health, the risks of the pandemic with a vaccination program? And I know that the NHS, a lot of my colleagues involved in vaccination delivery programs, we set up small groups, small surveys. I know Joan was involved in quite a few workshops where we're trying to motivate the BAME population to uptake the vaccine. There are campaigns, terrestrial campaigns to target the BAME population. There were social media conspiracy theories at the same time. And vaccine hesitancy is different from the anti-vax movement. The anti-vax movement believe that vaccines will harm us, they're not necessary, and that they're there to make financial gain for certain pharmaceutical institutions. But vaccine hesitancy really was about individuals thinking, you know, is this going to be right for me? Is this to my benefit? But we know that to defeat the virus, we need to vaccinate the individual, we need to vaccinate the communities, we need to vaccinate the nation, and we need to vaccinate globally for us to defeat this virus. The vaccine is the most successful tool, and yet we were dealing with this issue of vaccine hesitancy. So being a Black healthcare professional and listening to the data, looking on television, social media, realizing the risks, I thought it was important that we did a survey that covered a wide group of people in terms of the numbers, to begin to understand what the barriers, what were the predominant barriers to improve the uptake of the vaccine, what were the predominant facilitators to improve the uptake of the vaccine, because I could see that there was a higher risk of COVID-19 morbidity and mortality in the BAME populations. There was a higher proportion of BAME healthcare professionals in terms of mortality. They were the frontline workers with health and social care and transportation, construction, education, and we had identified other risks, but despite that, they were at risk. So it was important to try and tackle this within our population. As Joan had mentioned, the other risks identified were socioeconomic risks, say of overcrowding, multi-generational homes where the transmission was easier for the COVID-19 virus, age was a risk, learning disability was a risk, diabetes was a risk, and obesity were all risks, as well as other comorbidities. So just reflecting on the BAME population, which is the Black, Asian, and minority ethnic group. This is a heterogeneous population. It's a wide racial group from multiple continents of Asia, the Middle East, the Americas, Africa, and the Caribbean. And therefore, with wide ethnic diversity of cultures, foods, health beliefs, practices, religions, languages, differences even between the first generation migrants and the second generation migrants. And a significant proportion, as I said, were frontline workers working as health and social care workers. And therefore, they're a population at risk. And I felt a population that was important to explore about their views on vaccine uptake, because this was the tool that we know is the most successful tool in tackling this virus. So in March, which was when we devised the survey and sent it out, the data from Nafilian et al. Had shown the uptake of the vaccine in England was 67.2% in the Black African population, 73.9% in the Black Caribbean, as compared to the white population of 93.2%. And this was for the people that were eligible to vaccination, and there were mainly people at that time over 70 years. And we looked and found there was very limited and disaggregated data on the barriers and the facilitators to vaccine uptake for the Black African and Black Caribbean group. But even though our survey was conducted on the BAME population, our focus was really to look at the Black African and Black Caribbean populations specifically. The method we used was using an equivalent monkey survey called the WUFU electronic survey, which was sent via SMS texting the smartphones in people living in London, Leicester, and Kent. We did searches on GP medical softwares to identify BAME groups, but we also sent out links through social media networks of BAME groups, which included Black healthcare professionals from the Somali population, the UK Black pharmacist group. We also used West African school alumni groups as well. And the period it was conducted was between March to April 2021. Our target audience was to cover about 1,000 persons, and we actually achieved 834 respondents. The age group was over 18 years. So our survey demographics was to identify the age group, because as you know, the vaccination program was delivered using age as a risk, as Jonas explained, was a strong risk in health outcomes from COVID. And we knew that some people may not have been vaccinated at that time, so we needed to qualify age within the groups. Ethnicity was important in case our survey was completed by a non-BAME member, respondent. We looked at gender, and we looked at time resident in the UK. And that was to make sure that our respondents were people based in the UK, in case through the social media network it had gone out, globally, as happens. And we also wanted to look at patients living with diabetes. As Joan mentioned, there is a higher risk for COVID morbidity and mortality. So the questions were, do you intend to take the COVID-19 vaccine? And if you didn't intend to take the vaccine, what were the barriers? Was it a lack of trust in the healthcare system? Was it as advised by evidence on social media networks? Was it as advised by family or friends? Was it due to racism experience in the UK, or previous experience of discrimination in the health service, or other? And we had a free text box so people could give their opinions freely. Our facilitator questions, we wanted to know what would convince people to take the vaccine. Would it be advice from a faith leader, advice from a BAME healthcare professional, advice from family or friends, advice from social media networks, or if you felt the government was responding at the time to the Black Lives Movement requests on television. And we had the box for other again to give people an opportunity to express themselves freely. So we're now going to conduct a survey to see what our current audience would think and how you would respond to these questions.
Wonderful. Thank you, Gladys, for the information leading up to now. As Gladys has just mentioned, we're going to get you involved in the form of a poll. So we're going to ask a question. You'll see a box pop up on your screen, and click the answer relating to the correct answer that you think is shown on the screen. So Gladys, I'm wondering if you could take us to the question, please.
So, what percentage of respondents were unsure about taking the vaccine or did not intend to take the vaccine? And we've got three options: 14.5%, 35.5%, and 50.5%.
Great, so let's see how people are voted. Great, Glenys, can you take us through what the right answer is, please?
Yeah, as I said, our focus was on the Black African and Black Caribbean population within our survey because there is limited data relating to them, and because we felt that there was some form of stigmatization or negative reference to them in terms of their uptake. It showed that 14.5% of the Black African and Black Caribbean were not willing to uptake the vaccine at the time of our survey. 9% were unsure as to whether they would, and 5% did not intend to take the vaccine. So, and I think the recent data from the ONS is showing between April to June, there has been an increase in uptake of the vaccine by the BAME population by 68%. And in February, the data was that 44% were vaccine hesitancy, and now they're quoting that it's 21%. So this confirms what our survey is showing, that people just wanted informed consent. And as they've been reassured with various campaigns and communications through various networks, the uptake has increased. So we're going to move on to the next question, is what was the most commonly stated reason for vaccine hesitancy amongst the respondents? And this is with our 14.5% of Black African and Caribbean respondents. Was it a lack of trust in the healthcare system? Racism within the care that they have received themselves? Advice by family or friends? Or was it advice by evidence on social media? So as you can see, 45% of people who were hesitant to take the vaccine requiring informed consent felt it was lack of trust in the healthcare system. And this has been fueled by racism within the health service, as well as historical evidence of social injustice. 27% of them felt they'd experienced racism within the health service from the Black Caribbean population. 21% of the Black African population felt they had experienced racism within the health service, and it was a lot less in the other groups. So our next question was, do you think there was a significant difference in vaccine hesitancy between the white ethnic background group and the Black ethnic background respondents? Now, the reason we were able to have this question is that we did have some white ethnic respondents, and we discovered that they also had vaccine hesitancy. So we then compared our 14% of Black African Caribbean who had Black vaccine hesitancy with this white ethnic group who also demonstrated hesitancy. And we'd like to ask if you think there was a difference between the two groups. Okay, So interestingly enough, there was no difference in hesitancy between the two ethnic groups in our survey. At a p-value of 0.58, there was no statistical difference. So then again, this points back to our BME population requiring informed consent to uptake the vaccine. They're no different from the rest of the population. And maybe because of their experiences, they have shown evidence of a delay, but wanting to be convinced that this is safe for them, as with any other population. So we then looked at our people living with diabetes. And the question was, were the respondents more likely to be vaccine hesitant if they had diabetes? And taking into account, as Joan has shown and other data has shown, people with diabetes had a poor outcome with the COVID-19 infection. How do you think they would respond to being offered a vaccine? Are they more likely to take it or less likely? And I found this was very, very worrying for me as a healthcare professional, because our survey showed that there was a delay in the uptake of the COVID vaccine by patients with diabetes, and this was regardless of ethnicity. So we used univariable linear regression model to look at our respondents of people living with diabetes, and they were 3 times more likely not to want to take the vaccine. And even when controlling, adjusting for age and ethnicity using the multivariable linear regression, it showed that there was a 3.3 times chance of them being hesitant not to take the vaccine. I mean, there has been other evidence from other studies. Giraldi et al. Has also shown that people who are particularly at risk from severe COVID and mortality of COVID are less likely to take the vaccine. And we know that Black British people are 5 times more likely to have type 2 diabetes. And even when taking other risks into consideration, like socioeconomic risk, age, lifestyle, say obesity, diet, exercise, there's still a genetic risk for Black British to type 2 diabetes. It is worrying that they are hesitant in taking the COVID vaccine, which is a very successful tool to tackling the virus and to protecting them from worse health outcomes. So, our next question for our audience is, what was the most common answer to the question, what would convince you to take the COVID-19 vaccine? Advice from a faith leader, advice from a BAME healthcare professional, or advice from social media network? So the predominant facilitators to take the vaccine, we identified from our survey. And people had a choice. They didn't have to just choose one or the other. They could choose as many as they thought would facilitate them to uptake the vaccine. Advice from our BAME healthcare professionals was top. 41% of the Black African respondents would prefer that, and 40% of the Black Caribbean respondents preferred that. And this also made sense because people had demonstrated that if it was lack of trust and informed consent that was important for them to take the vaccine, then they needed to speak to people they would trust, people who would understand their cultural backgrounds, their communication styles, and where they would feel free to express their views, but at the same time trust that these are people within their communities who could explain to them within similar language and cultural expectations. The next group, which people preferred, was advice through social media, and 36% of Black African respondents, 30% of Black Caribbean respondents, and 24% of the other groups preferred social media. And this also makes sense because I presume in social media networks, you have groups of people that you trust, that you're engaging with, you're able to look at other people's views, you're able to express your views freely, it is convenient, it is accessible, and you can inform yourself in the way that you feel culturally sensitive. The advice from religious leaders was also significant, but not as with the previous two groups. So 22% of Black African respondents and 30% of Black Caribbean respondents would take advice from religious leaders. And that makes sense because in terms of informed consent, lack of trust in the healthcare system, they would not be able to deliver that message as well. Interesting, the other groups did not consider advice from religious leaders. So I think I'm now going to just reflect on some of the comments that people expressed in the free text boxes. They all relate to social injustice, either historical or personal. I do have hesitancy, as I don't know whether Black people were included in research to produce the vaccine. There is a long history of experimentation on Black and African people, and this has shown distrust in the wider population. This history needs to be reckoned with and rectified. Initial reservations about vaccination, but I need to hear more from people like me who I trust. There is not enough data on its long-term effect on the Black community. So I suppose I'm just not confident or trusting of the healthcare system. I would like the government to stop apportioning blame on recipients, but rather that they acknowledge it is their previous historical dishonesty, specifically with people of color, that hassled and continues to contribute to the mistrust amongst these prospective Black recipients. So those are all quite powerful comments. And I think in line with the recent George Floyd global human rights movement, people are freer and confident and supported in expressing their views. And maybe this is important because this is how we will tackle the inequities. Because the inequities, health inequities, which are differences in health outcomes between populations living in the same environment, has to be tackled, one, with the healthcare system's provision of health, being sensitive to our cultural rights, to, providing access, dealing with, disabilities, language barriers, geography, the cost of the healthcare, but also the health capability of the individual, which relates to their inherent health beliefs, their culture, their socioeconomic status, their educational level. So it's the two that needs to come together. And therefore, our recommendations is that for the research, to really engage BMA communities, to recognize that they're a heterogeneous group, to identify their specific inequities so that together we can work on this. I mean, a classic example is diabetes. The risk of diabetes is different at different BMIs. So the BMI level for risk of diabetes in the white population is 30, whilst in the Black African population it's 29.8. In the Black Caribbean, it's 26.2. In an Asian population, it's 23.5. That's the point at which we should be screening for diabetes. So the healthcare service needs to adjust to meet that requirement, to be screening people at those BMIs. But at the same time, the Black population needs to recognize that they need to address the issues of weight and health, which they can do, because if you lose weight, and you reduce your waist circumference, you're going to reduce your risk, reduce your BMI. We believe that targeted public health campaigns are important. The diabetes risk to COVID-19 is not just for particular ethnicities. So therefore, we need to target the public and inform them about that. And maybe patients living with diabetes are more likely to realize their risk-benefit ratio in taking the COVID vaccine, and making their decision would be more important for them. They'll make the choice to take the vaccine because they realize their risk is higher. Using BAME healthcare professionals in providing public information via social media campaigns will tackle the need for informed consent, which will be culturally sensitive and will improve the lack of trust that the communities are asking for in a convenient, accessible way. Avoiding stigmatizing populations by improving terminology, giving a positive promotion for vaccine uptake. Because if you are told that your population is vaccine hesitant, you might think, well, there must be some truth to it if Black people are not taking the vaccine. There must be some truth to why they shouldn't be taking it. So it's a double-edged sword, and then it reduces the uptake of the vaccine, and people then feel stigmatized. But making people realize that, hey, actually, it's a good thing. You just need more information to be convinced that this is going to protect your health. Then it gives people a positive view, the uptake of the vaccine. I think improving cultural competency within the healthcare system in the delivery of health, understanding of different cultural beliefs, cultural concerns, our communication styles, the experiences of the BME population will help the health service to deliver in a way that it will help the BAME population to make the decisions to accept care that is to their benefit. On Monday, I got an email from an NHS provider inviting me to a workshop, a seminar on reducing racism within the NHS. So I think policymakers are beginning to realize that this is important and an area to address, and this will have an impact on the uptake, not just of COVID-19, but also in the delivery of healthcare to the BAME population. So I'd like to thank all those who've participated in this survey. I'd like to thank the GP practices that have supported us, my colleague, Dr. Natalie Darko, who is an associate professor at De Montfort University in Leicester. I'd like to thank Sahiba Matek-Sands and Dr. L. Oster, who helped in preparing the statistical analysis. And of course, last but not least, family and friends who helped distribute the survey via social networks. This report has been forwarded to Public Health Hounslow, who told me they will be sending it through to Public Health England. And also we've distributed it to the wider GP networks. We're hoping to make smaller packaging to send this information also through social networks. Thank you for listening.
Wonderful. Thank you, Glenys. I think the results are insightful and really speak to the difference between vaccine hesitancy and informed consent, and what that can look like and what people would like to know. So thank you very much for sharing that information. And I hope that everyone involved enjoyed the polls. And it was interesting to see what people voted versus what the actual results were. Moving on to the next section, Glenys, you've already touched upon this, but I'd like to bring Joan into the conversation. Moving forward, what are the things that we would need to look at for healthcare professionals who are in the space of healthcare, caring for people who are living with diabetes in an environment where we have COVID-19, we're still in the pandemic, but then also for people living with diabetes in that same space. Joan, you have some great points I think I'd love to discuss with you now.
Thank you so much, Bernadette, and thank you so much, Glenys, for giving us such powerful information and current information. And I think what we've all learned is that if we don't learn from history, we're not going to go forward with success. So it's really important that when we're looking at the way forward, that we look and acknowledge the history and the historical concerns that people may have on the basis for that, so that we can look forward with a view to being successful. And how do we build that successful future for African and African Caribbean people, African and Caribbean people who are living with diabetes, and in the light of future crises? So all of the recommendations that you had arising from the survey, I absolutely agree with. And I think, fairly early on within this pandemic, Professor Fenton's review, which was looking with Black, Asian, and minority ethnic communities of about 1,000 people. He also surveyed a large number of Black, Asian, and minority ethnic communities to try and find out, as you would know from what my talk is, data, 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 and so data in terms of recording, because if we can't easily find the information about African and African Caribbean people who are living with certain conditions and how they are affected by certain infections or crises, then how can we find a successful way forward to better health? So that's one aspect of data recording. But the other aspect of data is research, and research that involves the community. So, participatory research. So, the community is an equal partner to the researcher. Absolutely, we've learnt from history, people need informed consent. Of course, trials now have to be ethical, but we also need partnership, because if we don't have partnership, we're not going to be successful. So it's respect for the community as an equal partner in participatory research. The other aspect to that is that the researchers, wherever possible, look like the community. And I'll come on to that in a little bit of what I mean by that. But we need participatory research, we need more research, we need more data, so that if other crises arise, we have that information in which we can quickly put into action the evidence that we gain. So without action, that data, that evidence is just ephemeral and nothing happens from it. If we're looking towards success for better health, we have to have action when we get the evidence. So early on, we found that people of Black ethnicity were at a disproportionate risk for adverse outcomes from COVID-19 infection. Action needed to be taken, whether that's risk assessments or other actions. If we talk about socioeconomic actions that could have been taken, protection for people to protect themselves, so to stay at home when they needed to, but giving them the support in terms of socioeconomic support that they required. Action without evidence is hopeless, but we're looking towards success. So that's data. What else do we need to do? Prevention. If we're looking to build better health for our communities, from the African and African Caribbean people, we need to look towards what we can do about health outcomes. If we're talking about cardiovascular disease, which includes diabetes, I believe, coronary heart disease, and certainly chronic kidney disease, how do we build better health? Well, things like prevention programs, awareness programs, and better health programs, again, arising and involving the communities adversely and disproportionately affected by these conditions, is a really important first step. Now, you may think that already there is information about prevention, already there is information about the conditions themselves, but somehow that is still not getting to all of the community that we need to get to and address. We need to reach out to those communities, respecting those communities, acknowledging that there may be some barriers to the messages, and finding the best way to get those messages across. Glenys mentioned obesity and the differential definition of obesity in different ethnic groups. Again, this speaks to something I'm going to talk about shortly about cultural adaptations and cultural awareness. So, obesity is not a one size fits all. It doesn't look the same. You may remember from one of the previous talks that we had that some communities would not recognize obesity in the same way. They might recognize, okay, if you do something about your waist, that's a good thing and better for your health. But a body mass index may not mean the same thing to them in certain communities as it does in others. And I think one of the other aspects that we really need to address is mental health. If we don't underlie anything we do with better mental health, then we're not going to get the success for overall better health that we require. It has to underpin everything that we do. Certainly in the pandemic, I think all communities, most people, if not everyone, has suffered in terms of their mental health to a greater or a lesser extent. The pandemic has had an effect not only directly in terms of the COVID-19 infection, but also the additional effects that it can have on things like people's mental health and also those wider determinants of health, socioeconomic health, social health, and other aspects of health. So I've talked about data and I've talked about prevention and I've talked about working with communities and respecting communities. And we need to have an equitable health service. It's now becoming more apparent that the health service is open for all, but not everybody seems to be able to get in equally. If we look at aspects like African and African Caribbean women's experience of child pregnancy and childbirth, for instance, if we look at African and African Caribbean people's experience of pain relief and the evidence that they are not given the same pain relief as people from the white community or the wider community. If we look at many different aspects of the health service, it has not been and is not an equitable health service, but going forward, we need to do what we can to make it a more equitable health service. So how do we do that? There is, again, all of the things I've said before in terms of things like data, in terms of things like prevention, but how you approach, how you communicate with the communities is vitally important. So it's okay putting a message out, but if that message doesn't speak to people from certain communities, they're not going to hear it. You have to reach out from the health service to these communities, and those messages have to be culturally competent. So therefore, they will need some cultural adaptations. Not every community, not every person is going to hear the message in the same way. And if you want an equitable health service, you have to make some cultural adaptations to your messages. New models of communication, new models of care, new models of prevention are going to help to make it more equitable. And these are quite exciting things in a way that maybe will come from this pandemic. It's been awful, absolutely awful for people who have experienced the adverse outcomes, not only mortality, but also morbidity arising from this infection. And going forwards, what we want is to build better health. So the final thing I would say, which came also out from Glenys and Dr. Darko's excellent report, was this trusted messengers. A trusted message, so giving the information that people are asking for, but the person who's delivering the message is also actually important. You will see that my colleagues and I in a local NHS trust reached out to our colleagues. And it was because we looked like our colleagues. They were prepared to listen. They were prepared to drop in their hundreds to drop-in sessions that we had on a weekly basis. And it's vitally important, as I've said, that you look at new models of communication, new models of care, but we need to build a network of trusted messengers for each individual community. So I think it is possible from this disaster of a pandemic, which has so greatly affected us all, to have better health moving forwards for the African and African Caribbean people. And so it is possible, but it will require work, and it will also require learning from our history. So thank you, Bernadette, and thank you, Glenys and Dr. Darko.
Thank you so much for that, Joan and Glenys. We've gone through quite a lot. There's a lot of take-home messages, very powerful comments coming from people who responded to your survey, Glenys. And moving on from that, we'd like to welcome questions from the audience. I know we've been having some discussions in the chat, but we're now going to address more of the questions right now in the Q&A session. Thank you so much. So we've got a first question in from Rosemary Mambua. Hopefully I've pronounced your name correctly, which is a great question about, does clustering and labeling people of African and Caribbean origin not encourage discrimination and biased practices, in particular when we're talking about the COVID-19 vaccine and diabetes? So if I could take that question to Joan first, and then also ask for comment from Glenys. People in the audience, if you have an opinion on this, please let us know in the chat so we know to welcome you to the conversation. So Joan, please, if you could answer the question first.
Thanks very much, Bernadette. And thanks very much for the question. Yes, well, I think that actually, I think I said this at the end, that we need data, and the data we can use as evidence, and we can use that to inform, and we can use that in a positive way. So I don't feel it is stigmatizing or discriminating. I think you do need information, and the important thing about using the information is to use it in a positive way. If you look blanketly, let's say, at how many people have been vaccinated, you might say, okay, so it's 80%, but that hides what's happening in different communities. So I don't think it should be used for discrimination. I think it should be used for data, for evidence, and used therefore in a positive way. Glenys, did you want to add something?
Yeah, I think it's useful information to know what different populations are experiencing. So there's a term called health inequity, which I think came into the public consciousness during COVID, when we realized that different populations living in the same environment, having the same access to the NHS, actually have different health outcomes. So for you to understand why that is happening, you need to, as Joan has said, get the data to see what the differences are. And in the past, when they've identified these differences, for example, the difference in maternal outcomes for women, both in their pregnancy experience, delivery experience, perinatal and neonatal morbidity and mortality, that a lot of Black women will give you their own experience, which is different from what other white women experience. And we think that these are avoidable, they're unnecessary, they're unjust, and they're caused by systemic, societal, and economic factors that are in the system. So some of them could be cultural, that, as Joan explained about Black women not receiving enough analgesia for pain control during labor because they're not perceived to be in pain, because the way they express themselves when they're in pain, it's not recognized as severe pain. So I think rather than saying we're being stigmatized or being discriminative, it's about positively identifying the areas of poor health outcomes and then investigating, getting the data and saying, well, how can we make a difference? And then we're going to get all of us living in the same, environment to have similar health outcomes.
That's great. Thank you, Glenys, and thank you, Joan. And I do agree with you that there are benefits in pulling out data for Black populations, but also the populations within that group are not the same. And so we have to also be careful that we don't generalize. But I think you made excellent points, both John and Glenys. I've got another question. It's actually related to one of the poll questions, which is from Danielle Morris, who asked, given the information we've heard about people with diabetes and in Black populations, should the COVID-19 vaccine be mandated? Glenys, I'll go to you first this time, please.
Yeah, that's a very good question and an interesting question. And it depends mandated for whom. So I think there are two groups. There are health and social care workers who are frontline workers who are at risk. And there's the rest of the population. So if we start with the rest of the population, we live in a neoliberal culture and we don't mandate for a vaccination. If you look at childhood vaccinations, we achieve 80 to 90% vaccinations across the country, and therefore we achieve herd immunity and lower the risk of those diseases by just educating people, allowing them to have informed consent. For healthcare workers, we do have a vaccine that's mandated, hepatitis B, for example, and that's really to protect the patients that we come across, because we can transmit that, say, during surgery or any sort of liquid contact. So, and it's also to protect ourselves because it's a really terrible disease and has some degree of mortality to it as well. And we've accepted that, and it's not a problem unless you have a contraindication personally to taking it, and then you don't take it. The other vaccine that's mandated is yellow fever when people travel, and that's also been accepted. So I think the COVID vaccine protects the individual from having a severe infection or from death or being admitted to hospital. It does not stop transmission. At the moment, we've seen that it doesn't stop transmission. It's the other restrictions, the social isolation, quarantine, masks, washing your hands, that's what stops transmission. So at the moment, I can't see how we can make it mandatory for the public. But to some extent, as a healthcare worker, something that protects you to 95%, it would make sense for you to have it. And I think it would depend on the politicians to make that decision, because if a lot of healthcare workers are needing to shield because they get ill, or there's there has been evidence of high mortality before the vaccines, it maybe they come to that conclusion as they did with hepatitis B. But I would find it hard to agree for the general population as we do with childhood immunizations.
Great. And Joan, do you have a perspective on this?
I can't add very much further, Glenys, to what you've said. I mean, I think the only thing I would say is that ideally you would hope that with sufficient information and also the information that people require, that they can reach that informed decision. And as a healthcare professional who believes that the vaccine does offer protection, I would hope that they would agree to take the vaccine. But I would hope that that would be through informed consent rather than it being made mandatory. However, I do understand the reason why that need in terms of public health might be necessary.
And it was interesting to see in the poll that 46% of the audience said that it shouldn't be mandatory. We had 80% who said they weren't sure, and then 36% who said it should be mandatory. So it's clear that there's a difference of opinion and everyone will have a good rationale for their choice. But it's a difficult one for our public health officials to make a decision on, for sure. We are running over time, but great that people are still with us in the audience. I've got a question from Joshua Williams. Great question. Just how can we apply the lessons learned here to the communities in the developing world with low vaccine uptake? And I suspect there'll be many common themes. Joan, if you'd like to take this one first, please.
Well, quite often what I've said in some of the webinars that I've done is each one teach one, and I'm a firm believer in that. So if you've learnt something from today's webinar, or maybe you've learnt it from some other event that you've attended, then you go and share that with other people. Because as Glennis's survey showed, our trusted messengers can be family and friends, as well as healthcare professionals who look like us. So if you feel that you've gained the information and knowledge that you require to make an informed decision about whether or not you take the vaccine, share that with other people, have that discussion with other people. And I think it's vitally important that globally we protect as many people as we possibly can, because, you know, we all have to be safe. And if some area of the globe is not safe, then none of us are safe. This is a global pandemic, and I think we have to address it as such. Glennis, did you want to add something?
Well, I was as you were talking, Joan, I was thinking about Matt Hancock, our previous health secretary, who realized that there's transparency and it's difficult to hide information. So I would say, not only are there so many BAME healthcare professionals, but even in research, and there's a lot of our community working in this field, with increased transparency and the global networks and information technology, a lot of information is easy to be dispersed. And it's, you know, so the evidence we have from the safety of the vaccine is really good. We know that these vaccines are reasonably safe. We know the conditions in which we can't use, say, AstraZeneca. There are two conditions: heparin-induced thrombocytopenic purpura and antiphospholipid syndrome. We know with Pfizer, if you've got an anaphylactic reaction of unknown cause, we can't use the vaccine. And I've worked in vaccine clinics, and apart from people getting nervous and maybe having a faint, it's gone really well. And so, yes, I think engaging in these sort of seminars, sharing the news, because we also need to help our African and Caribbean population, because if they trust us, then we need to pass the message on to say it is safe, it's going to protect you first and foremost, before it even protects the community at wide. And I think the developing world, their biggest problem at the moment is having access to the vaccines. That's what I understand. It's something like only 1% have been vaccinated. So that's probably the bigger issue. And hopefully by the time they get the vaccines, if we can communicate to our family, friends, our networks that this is safe and this is good for them, because their outcomes are poorer than the other ethnic groups.
Can I just add one other thing as well? That I think it's important to point out that in the trials for the vaccines, about 10% of the participants were from the Black ethnic group. And that actually is quite a high percentage compared to a lot of other trials. So not only do the messengers have to look like the community, but knowing that the people involved in the trials also look like the community is really important as well.
Absolutely. Thank you very much for that, Joan and Glennis. Thank you for the audience. We've had a great number of questions in the chat. Thank you very much, Joan and Glennis, for answering those. This has been the last in a series of 5 events, and we've been privileged to have the forum to talk about issues directly relevant to people of African and Caribbean origin. I'd like to thank Novo Nordisk for making this possible and enabling us to gather together to have such important discussions. For those people who asked in the chat, there will be a recording of this shared after the event. We will also have some other materials to support the learning and an opportunity to ask further questions. So I hope you have a lovely evening, everybody. And I hope to see you soon at the next Diabetes Africa event. Thank you so much, everybody.
Thank you.
Yeah.
Thank you.
Bye, everyone.
Thanks very much. Good night.
Thank you. Bye-bye.
Thank you.
Bye. Thank you.
Bye-bye. Thank you.
All right. Thank you.
Bye-bye.